All right, let's jump right in. We're going to tackle one of the most fundamental procedures you'll ever master, the Class 1 amalgam. And listen, we're not just running through some boring checklist today. We are going to break down the critical initial steps that really set the stage for a perfect restoration. If you can get these right, trust me, everything that follows becomes so much easier. So picture it. You're in the clinic, your very first patient is in the chair, and the chart says Class 1 amalgam. You can feel the pressure, right? Before you even think about grabbing the handpiece, what's your first move? This is that exact moment where all your preparation meets reality. Let's break it all down. Okay, first things first. Let's be absolutely crystal clear on what our target is. When we say Class 1, we're not just talking about a filling on the biting surface. The definition is super precise. And that precision, well, that's the key to getting it right. This is the anatomy you've just got to burn into your brain. Yes, of course, it's the occlusal surfaces of your molars and premolars, but it also includes those little facial and lingual pits on molars and even the lingual surfaces of the maxillary incisors. Knowing these locations inside and out it's fundamental to your diagnosis and your entire treatment plan. So now that we've locked in our definition, let's move on to the action plan. These are the absolute non-negotiable procedures you have to complete before any tooth preparation even starts. Getting this sequence right is what sets the stage for the whole restoration. I want you to think of this as a mandatory 3-step sequence. 1. Check the bite. You have to see how the patient's teeth come together before you change a single thing. 2. Give the local anesthetic. And 3. Isolate the tooth. This exact order is your blueprint for a predictable, successful start. Now, here's a great little pro tip on efficiency. You know that time you spend just waiting for the anesthetic to get the patient really numb? That's not downtime. It's actually the perfect window to get in there and apply the rubber dam. You save time, and you're ready to go the second the patient is completely comfortable. So, we've established that isolation is step 3, but it's not a one-size-fits-all kind of thing. This is where your clinical judgment really comes into play. What are your main tools for getting that dry, controlled field that you absolutely need? And this chart really lays out the decision-making process beautifully. Look, the rubber dam is your go-to for the more complex situations. We're talking deep decay, any concern about getting close to the pulp, and for proper mercury hygiene. It is the gold standard for control. But for a really straightforward case, like a small cavity on a single upper tooth, cotton rolls with good section can be totally fine. It all comes down to you carefully assessing the specific clinical case you're looking at. All right, we've covered the what and the how of isolation. But now, let's dig into the most important part, the why. Why is this step so incredibly critical? When you understand the reasons behind it, it stops being just another task and becomes a core clinical principle. And that's a fair question, right? It takes time, it can be a little tricky to place, so why do we harp on it so much? What are the actual clinical consequences if we don't get this right? Here are the big reasons, and every single one is critical. First, mercury hygiene. That's for your safety and the patient's. Second, amalgam is so sensitive to moisture. A wet field will totally compromise your final restoration. Third, and this is a huge one, it directly impacts your ability to save a tooth if you have a pulp exposure. And finally, the most obvious reason, you just can't do your best work if you can't see what you're doing. I want to pause on this quote for a second because it is so important. If you expose the pulp, and it happens, your chance of successfully capping it and keeping that tooth vital is significantly higher with a rubber dam in place. It prevents all that bacteria from the saliva from contaminating the area at a really critical moment. That alone is reason enough to become a master at using it. So what's the big takeaway here? It's that isolation isn't just another step in the process. It is a foundational cornerstone of good restorative dentistry. It protects the patient, it protects your materials, and it seriously increases your chances of clinical success. And that brings us to the end. As you start moving from the sim lab to the clinic, I want to leave you with a question to really think about. Of these first steps, assessing the bite, giving perfect anesthesia, or getting flawless isolation, which one do you think is going to truly test your skills when you have a real live patient in the chair? Your answer to that is going to help you focus your practice.